Please join me in welcoming Dr. Donohoe to the 2024 AMCSI conference.
Hi friends, I want to tell you that I do arthrogryposis. That is my thing. But I do see individuals with amputations on a regular basis also. So there's a theme these days that people are asking about amputations. It's a hot topic, so that's why we're here. So we're going to review the different types of amputations for lower extremity deformity. Not everybody has a positive outcome with the surgical intervention, but some do have excellent outcomes, and we're going to talk about some of that, the decision-making process. And we're going to talk about components and strategies for success. So let's give you some background on amputations. We'll give you a little information about prosthetic devices and what goes into the decision-making process. Talk about prehab. I think that when you're thinking about an amputation, prehab is really important because it helps drive what happens afterwards. And then the rehab process afterwards. And then we'll talk about what's coming in the future when it comes to prosthetic devices. So there's three types of amputation. There's congenital, there's traumatic, and there's surgical. Traumatic, we're not going to talk about. That's what happened. That's not today's talk. It's accident related or vascular related and not something we're talking about today. Congenital, some kids are born with missing body parts. So like this is a person that has, and I have to say my pictures are all Google-fied. So please don't share, they're not copyright approved. But this is a partial foot to an amniotic band, and you have these little nubbins at the end of the foot and a foot that is difficult to brace. And it's difficult to keep in a shoe. And so this is a perfect example of somebody that would need further surgical intervention to make that foot a functional foot. Surgical amputations are related to having a physician performing a planned surgical procedure to reduce the size of the limb. And that is the emphasis of this talk. Surgical amputation can be used to enhance alignment of the limb, or if it's a congenital amputation, or to make it a better prosthetic fit. A midfoot amputation for a club foot that has limited arc of motion to be able to cast effectively may be an option. We don't rush into it though. If there's a dramatic leg length discrepancy, sometimes an amputation would be considered. Sometimes it's done in coordination with other surgical realignment surgeries. It's so like an amputation for a toe that sticks up when you're doing something else, or that it's always causing problems in a shoe, or a toe that gets stuck underneath and is having skin breakdown. Take that toe off, it's not going to interfere, and then move forwards. Okay, am I going to be able to go? So there's types of amputation. You can do one side, which is unilateral, or both sides, which is bilateral. If you're doing a unilateral, you have to have a really good, strong side on the opposite side. The ability to hop is really helpful because if you don't have your prosthetic device on, to be able to get to the bathroom without an assistive device would require some hopping skills, and it would benefit from really good upper extremity use when you're not in the prosthesis to be able to use an assistive device. If you do both sides or a bilateral amputation, it gives you the opportunity for symmetrical alignment, allowing limited mobility without the prosthesis. So in a growing individual, someone who has like a knee dysarthritic, they can walk on the ends of their legs without a prosthesis for very short distances, but it's something that could be feasible. So let's talk about the different layers of process of amputation, and we'll start at the bottom with transfemoral. Does this have a laser? Oh no! Does it have a laser? It does not. It should.
On the bottom?
Oh, turn it on. Maybe that will do it. I turned it off with that.
Oh.
That top button was not it. Ah, there it is. Okay, so transfemoral. This is a transfemoral. You take it. It used to be known as the above knee amputation, but they've renamed it to be transfemoral. And then there's the knee disarticulation, where they just take the knee off at the joint. There's the transtibial, which they take half of the leg and leave the knee and have a good prosthetic fit. There's the ankle disarticulation, also known as the cymes, where they take the foot off, including the talus. And then there's the transfoot amputation, where they'll leave the heel and the talus, so you have a weight-bearing surface. So in growing individuals, the transtibial and the transfemoral are not preferred because they can have bony overgrowth of the amputation site. So we tend to go through the joint to allow growth and to allow that the extremity that's there to grow as long as possible, to have an equalization of leg length in the future. We're really not going to go into the specifics of prosthetic components. There's a lot of components when it comes to it, and a lot of terms when it comes to joints and prosthetics feet. The higher tech components, the caveat I want to tell you is we always start out low tech. So low tech is light, low tech is easy. Low tech is easy to get the alignment. As you get more high tech, microprocessors at the knee, microprocessors at the ankle, you're increasing weight. And I'll give you an example. I have a friend who had a relatively high transfemoral amputation due to cancer, and they had taken out some of his hip musculature, and he was very successful in a low tech device, but he wanted high tech. His low tech device was 8 pounds. He got a knee and it went up in weight. He got an ankle, it went up in weight. And now his leg is over 21 pounds without a shoe. And he has limited hip strength. So he has all of the bells and whistles to get his joints moving below the amputation, but then he has to manage it with a weak hip. So there are benefits and energy efficiencies of low tech for people that are a little weaker up the chain, because the weight of the device is really heavy. Let's talk about socks and sock liners, because when you're talking about an amputation, the key is to be able to put your device on yourself. A lot of times people are not comfortable in their braces, and if they're not comfortable in their braces, they think, well, let's just get rid of it and then I won't have to deal with it. But if you can't get your stuff on, it's really a problem. Or if you can't get your stuff off, it's really a problem. So the first line of action is always the stump sock. And the stump sock is a nice thing because you can have layers to adjust for how swollen or how small the stump has gotten. And it can help make the difference for growth or by taking layers out. There is the sock liner that goes inside the prosthesis for people that have external support. So you would have the sock, the thing that goes inside the prosthesis, and then you would have your sock on top of it. So it's a lot of layers. If you're thinking that, oh, let me take off my leg, it will be less than what my brace was. It's not going to be less. It's just going to be different. And then for those that are able to, there's a sock liner, a liner that has a pin fixation. So it will lock into the prosthetic device. And that usually happens after you've had your baseline prosthetic devices and they figured out how all the angles and figured it out for you. Prosthetics takes time. And so it's a process. It's not, you do the surgery and you're done. It takes time to get the right device. It takes time to get the right fit. And it takes time to move from a lot of support to a little support when it comes to wearing the device. Oh, let me go back. And if you can't get your own socks on before you have your surgery, the surgery is not going to get your socks on for you. So you have to have strategies for that in advance. So suspension is really important to me because suspension makes it so the foot goes the right direction. So a lot of times we'll start with higher suspension that gives a lot of rotational control, and we work on it because when you first get a device, there's a lot of change that happens with the limb. And so we'll use a suspension that requires a lot of support to be able to get that right. And so with a higher level amputation, we'll use a Velcro strap that goes up above the waist. And that really is helpful for getting rotational components and for slippage and things like that. But if you don't have the skills to be able to get that on and off, that's a problem because it goes under your clothes. And you can't wear it outside your stuff to be able to adjust it. And I've had some kids that they want to take everything off to go to the bathroom, and that's a problem because you can't do that at school. It's a problem. So for this, that's an example of how the pin device, the pin liner goes into the device. And to get it off, you have to have some sort of dexterity to be able to push and pull to be able to get it to go. And when you're putting this sort of device on, when it comes off, there's kind of like a pop to get it off. And then you can have, as there's change, you can go up with a longer sock or longer liner to be able to have it hold in place. Once you get the alignment right, there's these high-tech limbs that occur, but we don't start with high-tech because we need to get it right first. So if you have a foot amputation, some foot amputations can do really well in like a silicone foot. I can tell you that if you have a club foot and you have a leg length discrepancy, that silicone foot does not work well. You have to have a foot where the heel is aligned really well because otherwise you get a lot of skin breakdown on the front of the foot because the heel is still pistoning inside the device. It looks really nice in a flip-flop, but it doesn't necessarily feel really good if the alignment's not great. Typically, we start younger kids with an amputation that involves leaving their heel in place if possible, and putting them in a device that has like a trap door to be able to get them down and in and snugged in. It doesn't look as pretty, but you can walk on it really well. The silicone foot, you really should not walk barefoot in because it breaks down quickly and they're really expensive. So this is a nice option for somebody starting early. The problem with this device is you can't have any of the energy conserving stuff to help support the process. So you have a long leg that's stiff. It's like walking on a brick for the most part. So you have to wait later to get the next thing. But it's really functional, and I have some individuals that prefer that. And when we go to the next thing, they're not happy with it because it's been so stable and they are really adept at getting it on. Bilateral amputations. Now, this is the hot topic for the most part, I think. And this is the decision-making process in time. So a lot of times people will start off, we'll start off with things that are called stubbies, that are just like a prosthetic device with a foot on the bottom, so they can walk around, but they don't have a knee, there's no height to it, you can work on your balance. They use a support at the waist to get the rotational components correct. It's something I think of as a stepping stone. If you stay in stubbies, you're really short. So you have a really hard time reaching into cabinets, getting on and off of toilets, because you're relatively short. And if you have good upper extremity strength, it's great because you can still leverage yourself to get up. But if you don't have really good upper extremity strength, it's a wonderful place to learn your balance. It's a wonderful place to work on it. But functionally, it's a little limiting because of the height. Oh, I keep wanting to. So the next one is we add height to it. And when we add height to it, we have to work on the balance component, because balance is key to be able to be independent in your prosthetic devices. And you go from being really short to a little bit taller. It's like, for the typically developing individual, it's like walking on stilts. And I barely can walk in high heels. I can't imagine how my brain would work walking on a little extra height. But that's a training process, and that's a rehab process. And then you can go up higher and get free moving knees. But again, you have to have really good hips for those knees, because it takes a lot. And we have done research on falls, and we've done research in amputees, and we've done research in arthrogryposis with falls, and we haven't done research on the two together, but we'll get to that. So the decision-making process for amputation, we'll go through it each one. So we're going to look at age, the goal of the amputation, the strength, and the present presentation. So age, let me tell you, amputation is rarely the first option. We're going to go through a lot of things before we get to the amputation, because it's pretty straightforward, and it doesn't mean that it's the last surgery you'll have if you just cut off the body part. So we go slow. We do conservative amputations when long bones are growing, in order to maximize the growth potential. The problem with the conservative amputations is you can't have the hot energy giving back components until you have bigger distances and better stability and the ability to stay in the same prosthesis for a period of time. Because, young individuals grow fast. And when you grow fast, you're going to need new things relatively quickly. Insurance companies don't like to buy new things. If you don't have a device that fits, you can't walk. It takes time. I am the kind of person that wants it done now. I want it done yesterday. I want it to fit well. I want it to be great. And prosthetics makes me crazy because it's a slow process. They make molds, they fit molds, they bring it back. It takes a couple of months sometimes to get the right prosthetic fit to be able to keep you in a limb for 3 to 5 years. And when you have a growing individual, 3 to 5 years is not what that limb's going to last. So I think that it's really important to not do too early, because there's going to be a lot of growth spurts and a lot of challenges getting the device. And each growth spurt is the opportunity to throw everything off. Comfort. One of the reasons people say, I want to amputate, is it hurts. I want it to stop hurting. So if we just cut it off, it will feel better. Let me tell you, pain is real. Pain is real when you have a limb. Pain is real when you don't have a limb. So I think that it's really important to realize that sometimes intractable pain is intractable pain, and taking the limb off will just give you phantom pain that's intractable. So if you're thinking about doing something for your limb and it's pain related, you should work on the pain aspects before you get there, because it doesn't always get better. Sometimes it does. The younger you do it, the better you do it. But the older you are, the more likely you're going to have phantom limb pain or phantom sensations. And that can be very limiting also. And if brace wear is not comfortable to you, and you think that we'll just cut this off, it will be easier because I'll just have a leg. It's more layers. It's a lot of stuff. And if you have some floor mobility that's great with what you are right now, and then you take away some of the parts, you're going to lose some of your skill set. And that's why we often will talk about prehab to get you there. Positioning. If sitting in a chair is difficult and interferes with dependent transfers, sometimes it's a really good option to do an amputation to improve transfers. So somebody who's not an active participant who sits in a chair with legs straight out, they've been a really big fracture risk because the transfers are wonky. They do really well with a knee disarticulation because it makes them a little bit smaller and have less things to run into with the transfers. And I'm talking about individuals that are not ambulatory and do not have ambulatory potential. Those who have inadequate hip flexion may slide down in their chair or off the toilet if they don't have that counterbalance of their lower legs. So you have to consider what the hip bend is when you're thinking about an amputation and how they sit in a chair, because it may impact on how they're able to do really functional tasks. If there's a reliance on one leg for counterbalance when sitting, and the transfers it sometimes makes transfers harder. So let me give you an example. Like if you're sitting and the knees fall under the chair, you use that leverage to get the knee under the chair to be able to lean over. If you don't have the knee, the foot underneath you as like your pendulum to help move you back, you could be a topple out of the chair. So it's really important to consider how you use your lower leg in life and how you use that for transfers before you embark on it, because you may think that it will make positioning easier, and sometimes it will make it harder, and it might make it easier. Ambulation. The correct candidate for an amputation is going to be an excellent ambulator. No ifs, ands, or buts about it. The wrong candidate will be a non-ambulator and could risk a present level of transfer skill. And so you need to go into that really well informed, because you could lose skill. It may not improve it. Fall risk is real. Fall risk is real for AMC, and we did a study back at the 2019 conference and collected data, and there's a lot of falls that occur with AMC. And then Meg also works on fall risk in amputation, and the fall risk is like 50% fall on a regular basis annually for lower limb unilaterals, and 80% bilaterals. So fall risk is real. We don't know if AMC's fall risk improves or decreases with amputation because it hasn't been looked at. But it could amplify it, it could decrease it. We don't know those answers. So let's talk about muscle strength and motion before you make any surgical decisions, because that's a really important component in deciding how to do the amputation. So the area above the knee, the amputation needs to be strong. And hip integrity is of utmost importance, because if you don't have a strong hip, it really limits what you can do down the chain. And if you don't have good hip motion, it really limits how you can manage it down the chain. So if you have a really big hip flexion contracture, you're not going to stand up straight. It's going to be virtually impossible to get a good prosthetic alignment if you have a 40-degree hip flexion contracture. It's going to be a lot of stress on your low back. It's going to be difficult. Core strength is really important.